It is my pleasure and honor to introduce this session entitled TAVI Outcomes in Women. This is a very interesting topic. It's not because women are minorities, but because I think that women should be considered differently in our current practice. So I will go directly by introducing first Professor Sabine Bleisefer from Heart and Diabetes Center in Badenhausen in Germany, and Nicole Karam, Dr. Nicole Karam, which is an interventional cardiologist from European Hospital in Paris, France. I'm gonna hand it to you, Nicole, first, and then I'm sure we will have a fantastic session.
Yeah, I'm sure too. Thank you, Thomas. But before going into TAVI, I would like to start with a question to Sabine first and try to know more about the outcomes of surgical aortic valve replacement in women. Sabine, what you get for us?
Thank you. So we have a couple of data about that. These are all retrospective studies investigating gender-related outcomes after surgical aortic valve replacement. Female patients are represented in 30 to 40% of those patients. So first of all, female patients present differently to surgical aortic valve replacement. They are older. In some studies, they have more comorbidities, especially higher NYHA class or lower hemoglobin and higher risk scores. They, of course, have a smaller body size, smaller body surface area, smaller body mass index, and they also present with smaller aortic valve areas and higher gradients and smaller aortic root anatomy. Interestingly, they less often have an impaired left ventricular function, and they less often present with endocarditis. Next, there are a couple of procedural differences when looking at surgical aortic valve replacement. Because patients are older, female patients receive more bioprosthesis, they receive smaller valves. And we also saw in one study from my former center in Munich that they receive less partial stenotomy. We hypothesized that that was due to the fact that they are older and sicker. And finally, they have more surgical aortic root enlargements during the procedure. And concerning the outcomes, there are some conflicting data when looking at mortality. When just investigating raw data, in most studies, the surgical mortality risk, early mortality or 30-day mortality, is up to twofold increased comparing to male patients. But when adjusting for baseline characteristics, especially for age and comorbidities, in most studies, this difference is resolved. And when looking at late mortality among the studies, there is no difference between male and female patients. There are also some other outcome differences. Female patients have more patient prosthesis mismatch. So in mismatch studies, female gender is usually identified as a risk factor for patient prosthesis mismatch. In another study, we saw they have less wound healing disturbances than male patients. And I also found a different finding that there are different predictors for mortality among male and female patients. For example, a very small valve, 21 millimeters and smaller, is a risk factor for mortality only in male patients and not in female patients. So these are studies that are quite old sometimes, and we now have another treatment option for patients with aortic valve stenosis. And I would like to ask you, what do we know today about gender-related differences in TAVI outcomes? And is there a difference between TAVI and surgical aortic valve replacement concerning gender differences?
Yeah, indeed. Thank you, Sabine, for this great summary. So if we look at the TAVI results, they are very encouraging. Most of our data come from retrospective studies, again, if you want to compare, but we have the WIN-TAVI registry that prospectively included women in several countries. And it gave some very reassuring results regarding the safety profile and also the outcomes. So the one-year death or stroke rates were around 13.9%. The safety endpoint was reached in 14% of patients. Overall, the results were very good. Now, if we try to compare women to men in other studies. We have a large meta-analysis of over 47,000 patients worldwide, where around 49% of cases were in women. And here what we can see that there is a net benefit among women in all-cause mortality at 1 year. So again, good results for women, very encouraging. And if we go to surgery and try to compare what's happening for in TAVI compared to surgery, if we look at the partner study, we see that we had lower procedural mortality in TAVI versus surgery. It was of 6.8% with TAVI versus 13.1% in surgery. And this was maintained throughout follow-up, so very reassuring again. The rate of bleeding was, of course, lower in the TAVI group. I mean, I said, of course, but we could have been worried about the vascular access in women with small artery, but here again, it was not an issue, and it was very safe to perform TAVIs among women compared to surgery. There is another meta-analysis, this time including 1,700 women. And again, what we saw is that we had a decreased mortality at 2 years compared to what was happening to with surgery, sorry. So obviously, TAVI is a good option for women. Again, as you mentioned, you have this increased risk of mismatch with TAVI with women. But what we saw with TAVI is with supraannular valves, we do have good results. We do have a gradient that is acceptable. But I guess Thomas has more to say about this, right, Thomas?
Yeah, so thank you, Nicole. I mean, I would take it over after what you and Sabine have been mentioning. I mean, just to put this into perspective, I mean, TAVI in women is a daily challenge. And it's not only a trendy subject that some people are trying to be involved in. Two main things. Baseline characteristics show that women are sicker, more fragile, and that will make the surgical practice itself much more challenging. Sabine has been mentioning the need in many cases for enlargement of the annulus. And this is not an easy surgery for those who have tried to do it. And you have shown, on the other hand, that some non-randomized trials, not necessarily prospective, also have been showing a clear benefit in women. So I'm going to share with you this very important study. So this study is entitled Aortic Valve Replacement in Women with Small Aortic Annuli. And we involved in this study women that have been enrolled in TAVI and Evolute low-risk trials. So these were two randomized controlled prospective studies in intermediate and low-risk patients. And we looked at women who have had a diameter of less or equal to 23 millimeter. We looked at the presence of the PPM, but also at bioprosthetic valve dysfunction as defined by many criteria. You will see it later here. So first thing is that the baseline characteristics in this study showed no significant difference in age, BSA, STS score, NYHA, and other risk factors. The clinical outcomes at 1 month showed clearly that, Nicole has been talking about this, a bit more major vascular complications in the TAVI group, but all the other factors like acute kidney injury, like aortic valve readmission, and this is a very important point, have been in favor of TAVR. Of course, there was a pacemaker higher implant rate, but remember, this was before the cusp overlap technique. More importantly, and this will probably condition the durability of the valves, is the benefit of having better hemodynamic outcomes. So look at this slide. This slide shows clearly that we have had better EOA, significantly better from the day of implant and up to 1 year follow-up. And we have had lower gradients, significantly lower gradients from the day of implant, and this was sustainable over time. PPM, we have seen that also in women who have had TAVI versus surgery, they have had significantly less moderate and severe patient prosthesis mismatch, and this is what we wanted to show with this study. Total aortic regurgitation was no significantly difference between groups. That means that now we have reached a point where TAVR efficacy is here to stay. This is a very original and unique to be reported, extracted from this study also, that the Doppler velocity index at 1 year, you know, the higher it is, the better it will be. It was significantly higher from the day of implant till 1 year in the TAVI group in women with small annuli versus the surgical group. So in conclusion, this study, and you will have the chance to see more data and more results in the late clinical trials presentation. It showed clearly that we have had better clinical results at 1 year, fewer readmission, better hemodynamic performance at 1 year, significant greater EOA and DVI, lower mean gradients, and less moderate and severe patient prosthesis mismatch. So there is definitely a benefit to implant a TAVI in women following the conclusions of this study. Thank you.
Thank you, Thomas. Very interesting results. Do you think that those studies, this study is going to change our way of looking at the TAVI in women or at aortic stenosis in women overall?
I mean, you know, Nicole, I mean, we needed some data to support this observation that we know. I mean, Sabine and myself are hybrid surgeons. So we do TAVI as we do surgery. And we had this feeling that TAVI could be much better than surgery in many women. And this is the first randomized extracted data that shows the following. So I think this is preceding also 2 other randomized control trials that are coming, but this is definitely will make the field move forward.
Thank you, Tama. Very encouraging summary from you. So basically, we are very willing to perform more and more TAVI among women. But I don't know what's your opinion, Sabine. Do you think we have more data to wait for? Are you aware of any upcoming studies that we should look forward to?
Thank you, Thomas, for showing us these data. They still show only outcomes of one transcatheter heart valve. Maybe we need more data, comparative data for several heart valves. So we are all aware there is the SMART study upcoming, comparing small patients with small annuli, male and female patients, and we expect the greatest proportion will be female patients, comparing a self-expandable versus a balloon expandable valve. So this will also give us the direction for treatment of aortic stenosis patients in the future.
Sabine, I totally agree with you. However, if we don't have enough data so far, we have consistent cumulated data, and this study is the confirmation that TAVI in women should be considered differently, especially if we take into consideration the lower risk shift with the need for better hemodynamics. And we know that hemodynamics is a condition to get better durability, as we can see it, as you know. So SMART trial will look at all small annuli, but this data extracted from women subpopulation is really very important. And I think this is the opportunity to say the following. Indication of TAVI in women should also put in the confine of a heart team. And wherever we have any doubt about the outcomes in terms of fragility, surgical difficulties, and to quicker the release from hospital, I think the heart team should consider implanting self-expandable supraannular device in a woman.
Oh, very interesting point, Thomas. Thank you for bringing this up. Indeed, today it will be difficult to choose the correct management for an aortic stenosis if we want to go through heart valve teams. So to sum up, we've seen a very interesting session with, at the beginning, important data regarding the surgical outcomes, which are very good, but we still have this mismatch, prosthesis mismatch, and the need for alveolar enlargement, which is not performed systematically. So this was the little dark spot, let's say, in the surgical aspect. And then we've seen that we have good results with TAVI among women, which are very reassuring, and even some comparison that is retrospective, but it's giving some important data regarding the feasibility and good results of TAVI versus surgery. And then Toma, you gave us some very, very interesting results. And I wonder to what amount they will really change our upcoming management of aortic stenosis, and maybe, as you say, consider at some point TAVI as the first choice among women. Of course, the need for heart valve team and the need for a discussion to do to choose what's the best procedure, but also what's the best valve for the patient is very important again. So thank you all for attending, and thank you, Toma, for Sabine for this very interesting session.
Thank you very much. We enjoyed it. Bye-bye.